It's 07:30. A patient's, boy, I want to say this two ways, capillary and capillary. You choose. Patient's capillary blood glucose is elevated before breakfast. It's higher after breakfast and higher again by lunchtime. They report increased thirst and fatigue after eating. When you see a rising blood glucose pattern like this across the morning, what's the main reason behind it? And what's the first thing you should check before you assume it's the patient's usual diabetes pattern? This is diabetes need to know information, connecting what you learn to where you work, illustrating the why for beautiful science in your nursing skills. It's about readings, timing, and presenting symptoms. So let's start with the fastest win. Read the glucose trend. Treat blood glucose level or capillary blood glucose readings as a trend against time. I'll tell you, I'm going to say that word 5 different ways. Let's just keep moving. Direction and timing matter. 3 readings tell you more than one because you can see whether glucose is stable, rising, or falling, and you can connect that to meal timing and the clinical situation. Pre-breakfast high, after breakfast higher, lunchtime higher again. That's an upward trend. Pre-breakfast elevation often reflects what happened overnight. After eating rises are expected, but a bigger rise suggests more glucose entering the blood and a higher insulin requirement. A rising trend across the morning suggests the body isn't keeping up, or something today is making glucose harder to control. If the patient feels unwell, looks dehydrated, or the readings keep rising, you treat it as a higher risk and escalate earlier because the glucose trend might be part of a bigger clinical picture. Working through a mental checklist focuses your reasoning when you don't yet know the entire clinical picture, despite what the patient is presenting. Mental checklists are consistent ways of simplifying complex situations. In this context, we're checking diabetes readings. This is a skill which prevents you from treating readings as random. It's not a trial and error process, it's much more. It's it's where you take the items on your list and they must be tested against observations over time. And from the information you gather, you'll see whether the biology explains what you're seeing. This checklist highlights diabetes biology and provides, I'll give an example with each one, and we'll start with this. First of all, rising blood glucose typically increases insulin solution. So ask yourself the question, if glucose is rising, what insulin response should I expect? And do the patient's observations support that? Second, fasting and falling glucose typically increases glucagon. Here's your question. During fasting or overnight periods, is the patient maintaining glucose stability or are symptoms emerging? Third, acute stress physiology can raise glucose even without food intake because the body increases glucose production and reduces glucose disposal to prioritize immediate energy availability. Question, is this glucose rise occurring alongside physiological stress rather than eating? Take that into consideration. Fourth, medication context changes patterns because therapeutic insulin administration can reduce glucose quickly and can also reduce risk of hypoglycemia. Sorry, it can increase risk of hypoglycemia when dose, timing, and intake don't match. Question, what insulin was given, when, and what glucose effect should that create right now? Uh, Final question for now, number 5. Food structure changes patterns in after eating blood glucose levels and insulin demand. So what kind of meal was eaten, and does the glucose pattern match its structure? I'm going to cover this list with a lot more detail in the advanced version of this material. Noting these questions, let's move forward and consider this about diabetes to assist your reasoning. Diabetes mellitus and diabetes insipidus share the same presenting symptoms. Thirst, plenty of peeing, polyuria, plenty of waking up to pee during the night, nocturia, dehydration, fatigue. That similarity is a trap because it tempts you to assume the same cause. Your job is to separate the words from the mechanism. Is the body losing water because it can't conserve it, or losing water because glucose is pulling it out into the urine? Those questions and their answers lead to different assessment cues and different immediate risks. Diabetes mellitus is primarily about glucose regulation and tissue exposure to high blood glucose. Mellitus also carries tissue injury risk and acute risk patterns depending on the severity and the treatment. Diabetes insipidus is a water balance disorder in which arginine vasopressin, that's ADH, is deficient, or the kidneys don't respond to ADH, so urine can't concentrate properly. There's dehydration risk if water intake can't match the loss in insipidus. Pregnancy increases insulin resistance, which increases insulin demand, which can expose a compensatory limit. In gestational diabetes, pregnancy-driven insulin resistance often shows itself in after-eating patterns. Now, organize your frame of reference. If the primary indicator you arrive at is urine concentration control and water regulation, you are thinking diabetes insipidus. If the primary indicator is glucose control and metabolic stability, you're thinking diabetes mellitus. Similar presenting symptoms, different system mechanics. Let's look at some of the essential mechanisms associated with these processes. Simple physiology will explain why readings change after eating and between meals. Blood glucose typically rises after eating carbohydrate. Meals dominated by fats and protein with minimal carbohydrate often produce a smaller and less immediate rise, but they can still influence glucose timing, and they may cause a delayed rise in insulin-deficient contexts, particularly when fat and protein are substantial. I digress. The pancreas responds to the stimulus of eating and to the contents of what's being eaten by releasing insulin from beta cells. Insulin helps move glucose out of the blood and into tissues. It supports storage and it reduces liver glucose output when external supply is present. Between meals, when food isn't coming in, the pancreas releases glucagon from alpha cells. Glucagon supports glucose availability primarily by promoting release of glucose from the liver, including from glycogen stores. That pairing is the normal regulatory system. Insulin supports storage and use after eating. Glucagon supports supply when intake is absent. Diabetes begins when that regulatory system fails to match the physiological demand over time. So let's begin to distinguish the types of diabetes based on causation. Type 1 diabetes is primarily insulin deficiency due to an autoimmune destruction of beta cells. In that context, insulin is profoundly reduced or absent, and glucose handling becomes unstable without insulin replacement. Type 2 diabetes is primarily insulin resistance first, and then progressive beta cell strain. Insulin resistance means a given insulin concentration produces a smaller glucose-lowering effect in target tissues, so higher insulin levels are required to achieve the same glucose control. Early on, the pancreas often compensates by producing more insulin. Over time, that compensation may become insufficient, and sustained high blood sugar appears. Many people with type 2 diabetes can have high insulin levels and high glucose at the same time. That's not contradictory once you understand resistance and rising insulin requirement. Gestational diabetes is first recognized during pregnancy. The key orientation idea is that pregnancy changes baseline metabolism and insulin demand. Placental hormones progressively increase insulin resistance across pregnancy, which means the same insulin signal has less effect in target tissues. So the pancreas has to produce more insulin to keep glucose controlled. Many women compensate adequately. Gestational diabetes is the situation where compensation is not sufficient, and after eating glucose exposure becomes elevated beyond what is safe for that pregnancy context. Watch the dedicated gestational diabetes material for its own focused coverage. There's a lot to say there. Since we're looking at the mechanisms of insulin within the scope of diabetes, we better address the major modern driver of diabetes, and that's dietary choices, carbohydrate-rich foods and carb-rich ultra-processed foods. Straight up, removing these food or semi-food or non-food choices from our eating habits already goes a long way towards healthier eating and healthier people. Uh, Save that again for later. Carbohydrate intake raises blood glucose and stimulates insulin secretion. The size and the speed of the rise depends on the amount of carbohydrate, its form, and how processed it is. Ultra-processed foods are often digested and absorbed quickly. Think of it this way. Ultra-processed food, someone's already chewed it for you, and then you get it. Okay, anyway, I go, all right. It's often digested and absorbed quickly, which tends to produce larger and faster after eating rises in blood glucose and higher insulin demand, especially in a person who already has insulin resistance. In contrast, meals that are built around fats plus protein, optional greens, eaten to fullness, it commonly reduces the carbohydrate load and slow glucose appearance in blood, which tends to produce smaller after eating rises and lower insulin demand. The take home from this, blood glucose behaves differently across different eating patterns. Now, getting to know about insulin's role in diabetes also means that there are likely opportunities to alter its activities. You can get some leverage over some aspect of the mechanisms that are happening. Key leverage idea with diabetes is that you can change the system by changing either the signal, that would be insulin, the sensitivity to the signal, that would be insulin sensitivity or resistance, or the exposure that drives the signal demand, high or low glucose exposure from meals, for example. Insulin's a powerful lever to act on because insulin directly reduces glucose by increasing glucose uptake and storage, and it shifts potassium into cells. Now, whether the glucose goes into a cell or not, insulin will still cause that potassium shift. They are independent of each other, so keep that in mind. Uh, Potassium status is inseparable from safe insulin management because of potassium's impact on electrolyte safety and cardiac risk. Metformin is a different lever used commonly in type 2 diabetes progression because it reduces liver glucose production and it improves insulin sensitivity. Plus, metformin doesn't have insulin's direct potassium shifting effect. Different levers act at different points in the diabetic system, and the levers carry different risk signatures and monitoring implications. This is how you avoid thinking that diabetes equals insulin therapy or that type 2 equals lifestyle choices only. Both are incomplete. There's more to it than that. We're just going to start where we're starting. Let's look at some adaptive strategies that our bodies carry out. We have these strategies, which are physiological responses when normal activities are limited or impaired, and strategies produce recognizable clinical patterns. I want to highlight some key strategies associated with diabetes, with readings, timing, and presenting symptoms. Sleep restriction causes the body to shift into a defensive metabolic state, which worsens insulin resistance and supports hormones that oppose insulin's effects. And that can raise blood glucose and increase readings variability. Shift work disrupts circadian timing, and timing changes glucose regulation and appetite regulation. Financial pressure, time scarcity, they change food exposure patterns, including access to whole foods versus ultra-processed foods. Therefore, they change after eating blood glucose patterns. Stress and shame change what people report, which changes how accurately they're assessed. Blood glucose level trends can change quickly because illness and hospital routines affect the body. Infection can raise blood glucose. Steroids can raise blood glucose. Pain and stress can raise blood glucose. Poor sleep, poor sleep can make glucose harder to control. Dehydration can worsen symptoms and can worsen readings. On placement, you'll see this often. The same patient has different readings on different days because their condition, medicines, pain control, sleep, mobility, and intake are changing. If this patient is unwell, in pain, not sleeping, or on steroids, you expect higher readings even with the same meals. This is why you don't look at glucose in isolation. You link it to observations, intake, output, and the overall clinical picture. The main risk with these patterns and strategies is high blood glucose happening often over time, not one single reading. Eyes, kidneys, and nerves are commonly affected first by long-term high blood glucose. That's why diabetes is linked with vision problems, kidney disease, numbness, and foot complications. Over time, diabetes also increases risk to your heart, brain, and circulation to the legs. This is why the ward takes glucose patterns seriously and why consistent monitoring and safe escalation matter. If a rising morning trend keeps happening, the body is exposed to higher glucose more often. That's why improving patterns matters. Now we put everything into a simple pathway you can use for monitoring and escalation. Identify which diabetes you're dealing with, mellitus versus insipidus. Identify the dominant mechanism that's generating the patterns. Is it insulin deficiency or is it insulin resistance with progressive beta cell strain? Identify the dominant pattern drivers. Is it food structure, sleep, stress physiology, illness and inflammation, medication effects? Then interpret these readings across time rather than isolated numbers and assess the safety risks. Finally, act within your nursing scope. I'm speaking as a biomedical engineer and nursing educator. My role is to prepare you to engage effectively on placement with your patients, colleagues, ward preceptor, clinical mentors, lecturers, and regulated clinicians responsible for safe practice. That means I stress identifying and reasoning through information you can test against what you see, the intake, the output, what the body signals, how the tissues respond, and what are the risks associated with readings over time. This channel will help you develop clearer observations, stronger reasoning, and earlier, cleaner escalation and handover skills. The advanced version of this topic uses the same biology, but it's going to reward you with stronger terms and language around anatomy, physiology, pathophysiology, deeper conditional reasoning and learning pathways, and tighter links to the critical skills that support everyone's efforts on the ward. Make sure that your diabetes knowledge becomes portable. Master the orientation, move to the advanced. Diabetes connects to vascular risk, renal function and filtration, neuropathy and pain pathways, skin integrity and wound care, infection risk, medication safety, and fluid balance. High glucose can drive osmotic diuresis and dehydration risks in uncontrolled states. Insulin and other interventions can change electrolyte balance and therefore electrical stability in the body. Diabetes isn't a single silo of information, it's a physiological event reaching out into every aspect of health and wellness. See you soon. Be well.